All right, good. So let me go ahead and get started. So welcome. We have a pretty good crowd already, and we also have some residents gathering in celebration because today is General Internal Medicine Residency Day. It is the Grand Rounds annual day that is devoted to our General Internal Medicine Residency program. As a graduate of this program, I graduated in the year 2000, rang in the new century graduating from this program. I have a deep love for this program, as do many faculty members who have graduated here. From this program that you may not be aware of: Brian Bogner, Deborah Humphrey, Edward Catolo, Jeff Cooper, Ross Spector, Erica Abel, Ellie Marie Perez. We could keep going and going of all the stars. Candice Matid, Vaden Lal Das, Elizabeth Melzer, Dan Petter. I could fill the whole hour with just naming superstar attendings, both here at USF and throughout the country, who are educational leaders that have graduated from the USF General Internal Medicine Residency. I boast about our incredible ABIM pass rates, which once again will be highlighted by Dr. Oller and Dr. Kapadia in this talk. It is incredible how we remain a top 15 national scoring machine when it comes to the board tests, which reflect the incredible clinical knowledge and incredible innovation that residents learn during their residency, also matched, as we will see, by outstanding fellowship match rates and outstanding results as far as numbers for scholarly activity. Today's presenters are two of our finest graduates of our General Internal Medicine program, Dr. Kellee Oller and Dr. Nikesh Kapadia. I'll first start by introducing Dr. Kapadia, who I had the pleasure of working with directly during his training. He was a superstar as a med student, superstar as a resident. We were delighted to have him join our faculty. Hard to believe it's already been a minute, as I like to say, a good 6-7 years since Nikesh graced us and joined us. Nikesh is an assistant professor in our department, and now has about a few years ago, elevated to want to be one of our associate program directors. He has been very active in the American College of Physicians, and especially has excelled in the simulation arena. And so we look forward to hearing what he has to state in those regards. And Nikesh continues to shine brightly under the incredible leadership of our other speaker, Dr. Kellee Oller, who is our program director, hard to believe now, for over half a decade. I don't know how these years just go by so fast. I met Dr. Oller when she was a baby medical student, just a first-year medical student. She was the treasurer of my internal medicine interest group. So I watched Kellee go through the ranks as a superstar ACP National Jeopardy champion as a student with Dr. Brian Coe and Dr. Francisco Toronto as part of that great team. I saw her present at Philadelphia as she was recognized as a top 15 case conference. So she had quite a convention in Philadelphia back in that year of 2009. She was a superstar resident. She joined as an APD early on and promoted as Dr. Mai moved on to become our DIO. I'm proud to announce, as Dr. Mai has already internally, but now with October 22nd off, we can even shout it out to everyone. Dr. Oller is one of 10 winners of the Parker J. Palmer Courage to Teach Award that recognizes truly the top 10 program directors in the country. And no one could be any more deserving of this award than Dr. Oller, who just absolutely lives and breathes for the internal medicine residents. And I can't imagine how exciting it must be for the residents to have such a staunch advocate for themselves and such an incredible role model. So with that, I'm going to turn it over to Dr. Oller and Dr. Kapadia. Today is General Internal Medicine Residency Day. Today we should have the mayor giving a key to the city to Kellee. We couldn't quite arrange that, but as Vice Chair of Education, I'll give the key to the department, if Dr. Mosley allows it, to Kellee for her great recognition of her award and her talk today. Take it away, Kellee and Nikesh. Thank you for doing this.
Thank you very much. And what a wonderful introduction. You always know how to bring up very remote details. Jumping right in, because we have a lot that we want to talk about today. I'm going to start us off with these first two objectives, focusing on the annual achievements of our program and talking about our action plan that our program evaluation committee develops semi-annually, and sharing and collaborating with our faculty today on how we can really optimize meeting these goals in our action plan. And then I'll hand it over to Nikesh for the second half of the talk, which is really going to focus on point of care ultrasound and the applications of such in the program so far. And we have no disclosures today. So first, in terms of our program, we've really had a lot of growth in the last couple of decades and have leveled off to being at our full complement for quite a while now. There are 51 programs in Florida for internal medicine, and we are in the top 3 in terms of size. So we're on the larger end of a program, but I think something that's super important is it doesn't feel like a large program, and I think that's really a tribute to our faculty and our residents and really the close-knit relationship that we get working together at all of our hospital sites. Our graduates and where they go. So this was last year's class, and consistently it's over half going into fellowship. We have nearly half staying within USF in some fashion for their chief year, for their fellowship, for their careers, and staying within a component of our system, VA, TGH, Moffitt, the outpatient clinics. And I think that's something that we are extremely proud of. And I think it's really what kept me here all those years ago too, is really wanting to stay within this learning environment is wonderful. And even outside of that, we have a lot that stay within Florida. But I think we had a little bit more this year than usual, go back outside of Florida, often to, their home bases where they were before they came here for residency. In terms of the boards, we have a 97% board pass rate this year, and that's combined, including our medicine and MedPeds program. We don't have an updated 3-year metric like infographic yet, so it won't change too much in terms of our 3-year rate. I'd just like to point out, how this test is and how proud I am of the residents and the faculty for being this successful on the test, because it's certainly not an easy test. As you can see, the national 3-year average for the test has actually been going down each year for the last 3 years. So it's certainly a formidable test, and thank you for all of the work that you do for our faculty in teaching and preparing our residents for this exam, and for our residents in creating your board study plans, sticking to it, and preparing for this exam and for actually their next stage in their career. In terms of scholarly activity, this year we had residents with 71 presentations and 79 publications. This number is purely based, it's not per resident metrics, it's overall. So when you think about each resident perhaps collaborating on projects together, the overall number of this increases if you look at a resident scholarly activity all added together, but something that we're super proud of. Recruitment data is always fun to talk about every year. Sometimes I have my annual talk in the spring, and it's a little bit more focused on kind of year-end data and what the season looked like. So this is some year-end data from last year of how many students we interviewed for the categorical program. And then this is this year's data in terms of the number of applicants that we had to our program this year. This number is actually a little bit lower than years past, and this data trend down here at the bottom, I think really tells a little bit of the story of why with the signals. So for the prior 3 years, The applicants have had either 5 or 7 signals that they could use for a program. And one of the purpose of the signals was to perhaps, better target students' programs that they were most interested in, and programs target students that were most interested in their program to evaluate and evaluate for an interview. But you can see that it really didn't change. And in fact, almost there was a reverse effect on application inflation. So this year, with the change of having tiered signals, so applicants got 3 gold and 12 silver, was the first time in a while that even nationally they've seen a decrease in applications coming out. So I think this is really interesting data. I always love to kind of review this each year. It's fascinating, kind of the change of this and kind of working towards a better system that better matches applicants and programs with interested applicants, and trying to do it in a way that is not financially burdensome for students, especially. So this year, with over 700 signals, it's really helped us focus our holistic review, which does take some time. So we are still actually in that holistic review process within those that have signaled. And if we fill all of our interview positions through that pathway, then we probably won't really dig in too much into applicants that didn't send us a signal or have us in the top 15. So just kind of interesting to think about and see the evolution of this and how it will continue to change in the years to come. Next is, we're going to dive into the action plan, and this is kind of pulled from the ACGME program requirements. Part of building an action plan with the committee is also really distributing it and discussing it with residents and faculty, so everybody can be on the same page with what our goals are and innovations for this upcoming year. So we're going to dive into a few more in-depth action items, and then we'll kind of have a list of highlights of other key initiatives that have been a big focus of change for this year. So the first, we're always looking at any sort of work hour issues and really optimizing the schedule as much as we can. I think there are some things that, we're doing well with. It's very rare for a resident to have an 80-hour work week consistently averaged over a 4-week period. These numbers here are the percent compliant that we are on the ACGME survey. Residents are not working more than 28 consecutive hours of work. There's a whole host of other ones there that, that relate to at-home call or things that don't even really apply to our program that we have no issues with. So lots of things that we're doing well with. Some areas for improvement that we found on this year's survey was the day off per week averaged over a 4-week period, right? So having 4 days off in a 4-week block or 2 days off, at least in a 2-week block. And our compliance, even though it was, really above the national specialty average for internal medicine, I think it is something that there's really no reason why it shouldn't be upwards of 100%. The other thing that didn't come up as much on the survey, but has been data that we've been tracking is the time off between shifts. And really this becomes more of an issue on a long call shift if something runs late or if there's rounding, and giving residents enough time off to rest before coming back in the morning. And looking at the data of these for the last years, you can see our 80-hour violations were really minimal. The day off violations, again, kind of thinking about the numbers in our program, if we have 120 residents and that is multiplied times 365 days that they could potentially have had a violation, right? These numbers are really small, but it is something that we want to work towards, and there's no reason why we can't be at 100% compliance with this. And then you can see the more common issue that we have with violations is that short break. And so having enough time off between that long call or the afternoon call shift and then coming back first thing in the morning. So in terms of that, some interventions that were that were started was one, having senior residents truly have a day off on wards free from any patient care activity. So in our feedback sessions after the survey results came out, that was really identified as, I think, one of the big factors for that survey result with ACGME. We started a pilot in the spring with attendings fielding a phone call on one of the weekend days. Stuff that we need help with. I'll have you read this for a minute while I take a drink. So for our faculty, I think, working with, when you're on wards, working with your senior and planning your phone call days off, ahead of time for the weekends. If your senior resident is the Saturday PM call senior, thinking ahead, are they going to have the Sunday off? If they're rounding Saturday night, that's fine. If not, and they're working that full weekend, then a different weekend needs to have 2 phone calls taken by the attending to ensure that they have that average of the day off per week during that rotation. And then when staffing admissions on the PM call days, I think, classically Friday, Saturday night is when we do a lot of nighttime staffing. Being mindful of, still getting our residents out on time. To have 8 hours off between their shifts, they would need to leave by 10:30. So they would need to be wrapped up even a little bit before then. That way they can prepare sign out and tuck in their patients and do any documentation that they have left to do. So I think that's something that we can really work on, both from the faculty and the senior resident side, is really collaborating with more efficient rounds, particularly in that setting. If you're staffing during the long call shift. Starting maybe with one intern side of the patients, staffing those, and then releasing that intern to get work done, and then calling up the other intern to staff the other side. So really think about efficiency. I think another thing that could be helpful is having an early intern that would leave earlier and come in for the house officer handoff, and having maybe an intern that would stay later and then come in later in the morning, or kind of staggering their shifts. We definitely want to encourage our residents to continue the accurate logging of these hours and new innovations. It is really our way of determining what the current, situations are with the hours. And if there are violations or anything like that pop up, Chantal does reach out if there's not an explanation in NI logged. And that really just gives us more data that we can use to see if it was an unusual night, which can happen, right? A patient can decompensate, and you're really working hard as a team to stabilize that patient and get them the care they need. And maybe you didn't get out on time because of that, and that's okay. So we just really kind of reach out to ask more questions about the situation that led to that. I think the other thing that we need help with is just ensuring that our interns are also getting their days off within these 4-week blocks of ICU and wards. It's something that is created at the start as a team. And just be mindful that this is captured in a rotational experience. And the rotation on wards for our interns ends on a Tuesday. So for our residents, you can't look at that weekend after they leave wards and say, oh, well, they have days off coming up this week. They're within their numbers. Because those aren't captured within the rotation. They need to have their days off within that block. And we have had even an issue come up with that this year. So that is something that we definitely need everybody's help with, ensuring that we're compliant with everybody getting their days off that they're intended to have. And then here's a wonderful infographic from Chantal, just a reminder about logging your hours. All of your hours are due by the 2nd of the month. So if you're doing a great job and kind of logging them as you go along, except for even the last couple of days of the month, if you forget to log those days, you're still not compliant with getting your hours in, and you'll be reached out to get them in so we can review them. You don't need to log vacation under your work hours. And then you do have a long list of options here that you can use. For the vast majority, all of your logging should be under rotation. There's only two exceptions to that. One is if you're away at a physical, conference where you're presenting, you log as conference. Or two, if you're on your 24-hour MICU shift and you are staying after the 24 hours to finalize care or do handoff, then you would log those hours after the 24 hours as post-call transition time. Outside of that, just remember everything should be logged under the rotation work hour type. And Chantal will be sending this out with her next reminder at the end of the next month. The second action plan item that I want to talk about is feedback on rotations. So things that have been going well, the on-the-spot rotations have really improved feedback conversations in the electives and the clinics. Last year, we had over 600 feedback moments submitted. We've seen steady improvement in compliance with satisfaction with faculty member feedback. And 2 years ago, it was 64%. This year, we're at 79%, and I would say significantly above the national average, but still an area that we feel like we can continue to grow in. Again, we're asking for timely completion of the evaluations and new innovations for wards and ICU blocks, and for our faculty to really partner with our residents when they bring those paper on the spot feedback forms. And just a reminder, those are formative. So those can be feedback related to that clinic patient they saw with you that day, or that consult they did when you're on rounds and staffing and their engagement with that patient and running the show in the room on rounds. For residents, again, reminding about compliance with requesting the on-the-spot evaluations. This is something newer this year where we're having it on all of our rotations, including wards and ICUs and even nights if you're engaging with a direct supervisor. And then also with selecting your faculty evaluator and sending them your new innovations evaluation. And then there's some things that we need to improve on a program level. We did have challenges with the accurate matching of faculty due to the accuracy of schedules received, which is why we went to this self-selection of faculty evaluators to make sure it was accurate. And then sometimes we do have issues with the faculty evaluators and the permissions that they have per rotation. So those are some things from a program level that we're working on. So again, interventions that we started this year, those on-the-spot evaluations are being used for every rotation. So if somebody is on a core rotation, they'll have an on-the-spot evaluation and a new innovation evaluation. If there are fellows on the rotation, such as MICU, CCU, a fellow can complete that paper on the spot form because the faculty member is also getting the electronic one. The other intervention is residents selecting faculty evaluators and new innovations to help reduce that incorrect pairing of evaluations in the system. So again, what we need help with is, again, timely completion of those evaluations, that matching process that is now not something that's automated and self-selected. And then if you do encounter any issues with faculties not having the correct presets or in the system, please reach out to us so we can continue to optimize that system. I want to take a moment to also show new innovations. So if you have, for our faculty members, if you happen to want to give feedback to a resident and you haven't been sent an evaluation, you do have a way to select the feedback yourself. So within new innovations, right, kind of getting back to the dashboard, you would go to your evaluations that you need to complete. You would click under Create Evaluations, choose a subject. You would put in the resident that you want to evaluate here, and I'm just using one of my chief residents as an example. You click the type of rotation, and then just a note, don't stop here when this evaluation comes up. Come up here and make sure that this information is correct. So you can drop down and pick the correct team assignment that you worked with them on, and then also the correct date assignment. It's going to auto-populate to their current rotation and their current block. And so if it was it was the block before when they wrapped up with you and you're just getting into the system to do the evaluation, please go up to that top corner and change the things just so that way it's mapped to the correct time period for us. And then the third and final thing, the action item that I'm going to go in depth is really teaching, education, and curriculum. This year we had 270 organized talks from guest speakers across the 3 sites in our academic half day. Our subspecialty education coordinators assisted us with rounding up faculty. The GQ medical student survey rated internal medicine really above the national average in terms of effective faculty teaching. And then I want to give kudos to our residents who scored even higher on effective resident teaching. Some areas for improvement identified on the survey was the balance between education and patient care, protected time, appropriate amount of teaching in clinical and didactic sites. We're all under the national averages and something that we hope to improve. We adjusted the call structure this year at the VA to really avoid ER admissions during conference time to protect that didactic experience from admissions. Our outpatient faculty is working through and revamping the Friday morning experience for learning in the ambulatory setting. For our faculty, just a reminder about the GME event calendar. So if you even just Google GME faculty development, you can click into their event calendar and sign up for faculty development. There's already a whole host of things here in October. And then again, we also have openings in our schedule for subspecialty speakers that we're booking towards the end of the academic year. So please reach out to get on our schedule. And then I'm not going to go through all of these, but these are just some other examples of things that have been enhancements or highlights or different things that we have worked through changing in the curriculum or in systems things within the program or the sites for this academic year. So just some fun highlights there. And I want to end my section with really saying thank you. Our faculty do so much for our residents in terms of workshops. We had, teaching to teach or palliative care workshops, which are annual things. We also had new adventures such as the narrative medicine workshop, the cost conscious care case. So thank you for partnering with us to deliver this curriculum. Simulation, that includes our ACLS and BLS courses, our POCUS workshops, mock codes, procedure training, career mentorship from assisting with semi-annual meetings to serving as a gateway mentor to hosting, and doing our fellowship fairs, board review. We have board review at all of the clinical sites and the academic half day, the big 4-day experience, and really just down to the teaching on the wards and in the clinics. It really all adds up in the preparation of our residents for practice after. In terms of scholarship, thank you for your mentorship for our residents and their research projects, including quality improvement and medical education, for creating regular opportunities for research networking, encouraging them to take their unique patient cases on the road and serve as teaching moments for others. Evaluation, I don't really have a great picture for, but thank you for giving feedback for the evaluation submitted through NI and on the spot form. So thank you for taking the moment in your day to give feedback to propel our residents in their continued growth and development. Thank you to the Clinical Competency Committee for your tireless work, again, to elevate the progress of our residents as you meet each month and for our big milestone meetings. For building community, for creating a positive culture in the work environment, assisting with recruitment of individuals that carry our same mission, for creating safe spaces and affinity groups for our residents to connect, for our DICE committee, our recruitment committees. Thank you to our program leadership. I don't have a big group picture of all of our APDs, but to our APDs, to our chief residents, to our program staff, thank you so much for, again, helping with our program mission and really the running of the program. And so with that, I will stop sharing and hand it over to Nikesh to continue the second half.
Hey, everybody. Can you hear me?
Yes.
Perfect. My name is Nikesh Kapadia. Thank you for the introduction, Dr. Lazama and Dr. Oller. I'm one of the associate program directors. I started this year, actually. It's a privilege to speak to all of you. I don't have any disclosures, but I did have some acknowledgments. I really wanted to thank Dr. Oller for her promotion of point-of-care ultrasound in resident education, and also wanted to thank my mom and dad for supporting me. I wanted to discuss kind of how ultrasound came to be where it is today. So a brief history of ultrasound medicine. I wanted to talk about where we're at today with ultrasound with common diagnostic applications and what do we do with it going forward with some accomplishments we've had in opportunities in curriculum with ultrasound. So this is a brief history. Really in the 1950s is where ultrasound as we know it today started. It was very archaic. We had this dunk tank where we dunked patients in to generate low quality 2D images. But around this time is where the kindlings of echocardiography, GYN, and obstetric ultrasound started. In the 60s through the 80s, it progressed. This is actually one of the first images of an obstetrician doing an ultrasound. Technology progressed too. So Siemens released the Vitson, which is a real-time scanner with 15 images per second. Phased array technology, which is the type of probe you use for a cardiac ultrasound, organs in motion started. European surgeons started using ultrasound in trauma. In the 90s, really, there was a lot of adoption. So the FAST exam to evaluate for trauma diagnoses and specifically intra-abdominal free fluid was incorporated into the advanced trauma life support guidelines. And it was increasing in use in procedural guidance, particularly central venous cannulation. Current guidelines recommend ultrasound for all IJ central venous catheters. But quietly in the background, there was literature being developed on diagnostic lung ultrasound at the point of care. And this is where internal medicine point of care ultrasound, I think, really got its start. So in the 2000s, there was the era of acceptance. So an enormous number of professional societies and training programs incorporated into their practice. For example, the AMA said that ultrasound is within the scope of practice of appropriately trained physicians. CHEST had it allowed for integration of, made a position statement asking for integration of ultrasound into critical care training for fellows. In fact, the emergency medicine residency required 150 or 300 ultrasound scans to complete residency. Technology also progressed around this time where portability of the scanners, ultrasound scanners, improved. And then we kind of arrived where we're at today. We went from the dunk tank that you saw the picture of, that really low quality OB picture, to portable ultrasounds, to today even having handheld ultrasounds you can use on an iPhone. We went from piezoelectric crystals to semiconductors. We went from it being esoteric field with very few adopters and users to now being integrated in medical school education. There's old data from 2014 that said 62% of med schools had integrated ultrasound into their core curriculum. And there's now artificial intelligence integration and protocols being developed for standardized examination. So what is the place and case for ultrasound in internal medicine? It kind of evolved. It was used in resuscitation and cardiac arrest. If you think about all the H's and T's of reversible causes of cardiac arrest, tamponade, pneumothorax, massive PE, a lot of them can be assessed with ultrasound. It was used in the primary care setting for a variety of reasons. Procedural guidance has increasing utilization of ultrasound. And then kind of the new thing, the innovation, has been diagnostic ultrasound. How can we use ultrasound in diagnosis? So anything your eyes can see, your ears can hear, your hands can palpate, the ultrasound can help you augment your physical exam. You no longer have to wonder what those lung sounds are. You can diagnose interstitial lung syndromes, alveolar consolidations, pleural effusions on ultrasound. You don't have to wonder what that murmur is. You can look at the heart. You don't have to wonder if it's chronic kidney disease, acute kidney injury, obstructive uropathy, various types of kidney injury or kidney disease. You can image the kidneys. You can identify changes of rheumatoid arthritis on ultrasound before physical exam or even X-ray diagnoses. And that kind of brings me to why I think I got into ultrasound. I think a lot of learners do too. Why did you decide to become a physician? For me, it's becoming an internal medicine physician really grew out of admiring people like Dr. Oller and Dr. Mai and Ledford and O'Brien and Navarte and many others. It was watching them apply generations of iterated science and skills to an art of caring and healing people. They examined patients closely and listened to their stories. They deeply understood their lives of the patients and improved their lives. It inspired me to understand the practice of medicine as more than a job, it's a calling. This is a painting of Renee Laennec examining a patient with TB and with an early stethoscope. And this is kind of my conceptual understanding of medicine and why I chose it. And I think a lot of us too. It's the doctor physically examining a patient, applying his deep knowledge or her deep knowledge to caring for them and making their lives better. How is medicine practiced today? I think it's a little bit different than that concept. Rather than a direct involvement of the doctor and physician, there's layers and filters between us and our patient. And this is from an article from Atul Gawande, where he cited data that for every 1 hour we spend directly facing a patient, we spend 2 hours on a computer. I think it changes that calling a little bit. And to me, the reason I was interested in ultrasound, I think a lot of learners are too, and I think it's part of the future of medicine, is its real innovation is its return to the bedside. POCUS represents an innovation that brings us back to the art of bedside care. It restores the important connection between a clinician and a patient. It enhances diagnostic precision while rekindling the essence of our calling in medicine and blending the advancements of technology with the timeless value of hands-on healing. This is a picture from an African village where the WHO is applying ultrasound and the TB protocol to diagnose TB using ultrasound. So that's how we got here and the why. So let's look at examples of applications and where we're at today and why it's important to use. So, there's numerous diagnostic applications. Anything with a physical exam can be enhanced with point of care ultrasound. So this just give you a couple examples. This is an example of an ultrasound, a 26-year-old male with Hodgkin's lymphoma that came in for dyspnea. An ultrasound of his chest revealed this black pleural effusion with this spiderweb-like septations. You can imagine looking at this. This is not a simple effusion where thoracentesis is going to cure this patient. The ultrasound, as opposed to an exam or an X-ray, will give you significantly more data that's going to alter this patient's course through care. So let's compare a pleural effusion for evaluation of pleural effusion with physical exam versus ultrasound. So common physical exam techniques have positive likelihood ratios around 5 for pleural effusion. What is it for ultrasound? 23. It's virtually diagnostic. When we compare pleural effusion evaluation of ultrasound versus common imaging modalities, where does it compare? So if you look at the specificity of X-ray for effusions, it's not bad. Sensitivity is not quite as good. We know it's not as sensitive for pleural effusions, particularly small ones. There was an exception in one of the studies, particularly in trauma patients. But if you look at ultrasound, both the sensitivity and specificity across studies is quite a lot better. How often do we have this presentation? A patient with heart failure and COPD presenting for dyspnea, and we have to differentiate what's causing them their difficulty breathing. You could put a probe on their chest and find this pleural line with these laser pointers emanating down that indicate fluid in the alveolar interstitial space that is a very, very specific marker for alveolar interstitial fluid and pulmonary edema, and you have your diagnosis within a few seconds. These are called B-lines, by the way. So how does cardiogenic pulmonary edema, how does the evaluation physical exam compare to ultrasound? How is it augmented? Physical exam is not terrible. Negative likelihood ratio is not significant, but positive likelihood ratio is around 3 or 4. How does ultrasound compare? Even by novices, non-radiologists, the positive likelihood ratio of the B-lines you saw in the previous image is 12. It's virtually diagnostic. This is actually an image I'm sharing from one of our resident learners. So not an expert, but somebody who went through our course, and they gave me permission to share this, and their spouse gave me permission to share this. This is an image of their spouse. They happened to have an ultrasound scanner and their spouse around, and they popped an ultrasound and they saw these gallstones. And, to continue the story, a few weeks later, their spouse had severe right upper quadrant abdominal pain, and they put the probe back on and correctly diagnosed them cholecystitis and got him correct emergency treatment right away. For novices, the likelihood ratio of gallstone detection is 7.5 for novices. So another example, even a more complex case, patient with HIV and asthma coming in with dyspnea. This is a lung ultrasound, and you can see over here the air bronchograms, which are these white areas which represent air going through the black consolidated lung or the gray consolidated lung. Very highly specific for pneumonia. This is an image that we actually just got last month, actually a month ago in September, on the point of care ultrasound course. Residents found a patient with pneumonia in the ICU, and they were having persistent fevers despite being on correct antibiotics, and they found this complex parapneumonic effusion, likely the cause of the persistent fevers. And shortly after obtaining this image, they showed the ICU team, the patient got a chest tube, and I think they got better. In fact, they did get better. I had the patient later on. So how does our exam compare to ultrasound for pneumonia? Exam is pretty bad. Our crackles are not very high likelihood ratio, but it adds to our Bayesian analysis. How does ultrasound do when we find what we did on the previous slide, consolidation? The likelihood ratio is 13.5. There's an enormous difference there. Even when you compare to X-ray, the pooled diagnostic odds ratio for diagnosing pneumonia for ultrasound is 24-25. For X-ray is 1.73. Just continuing on with a few more examples. If you have a patient with dyspnea, we had a patient with dyspnea and history of amphetamine abuse. They popped an ultrasound on the chest and found evidence of this cardiomyopathy with a severely reduced ejection fraction confirmed on other images too. Even for novices, there are protocols being developed to quickly rule in or rule out various diseases based on the chief complaint, like the blue protocol for a dyspneic patient. There's also ways ultrasound helps augment your history and physical for patients with non-specific complaints. So this is a patient with fatigue, and as you can see here, they diagnosed them with a right atrial myxoma with this intracardiac mass going into the right ventricle during diastole. So this is another example of a learner. I had a patient who came in with pleuritic chest pain, and the learner put an ultrasound probe where they were having pain on the right upper quadrant and found this liver abscess as the cause of their pleuritic chest pain. Think about their pathway through a hospital traditionally. They may have gotten a CT scan of the lungs, an X-ray, maybe cardiac biomarkers, enormous amount of testing that may have been negative and wouldn't diagnose this patient. And ultimately, ultrasound would have been good enough to initiate them on the right pathway. So that's how we got here, a history, where we're at today and why it's important. And then what do we do? How do we teach point of care ultrasound? I'm really proud to say that we have multiple modalities of teaching point of care ultrasound. There's obviously growth to do, but we have a point of care ultrasound course. We have multi-site use of POCUS. We have POCUS workshops, as Dr. Oller highlighted, and procedural ultrasound. Something I'm really proud of is the point of care ultrasound course. Dr. Valenzuela and myself built this course based on the position statement from the Society of Hospital Medicine on POCUS for hospitalists. We separated the domains of knowledge, learning into basic knowledge, image acquisition and optimization, interpretation, and clinical application of ultrasound. And we developed curricular material to help solidify these domains of expertise among our learners, from delivering asynchronous and synchronous content, case-based conferences, live scanning with learners, independent scanning and feedback. And one of the things I'm really proud of is requiring scholarly output and an image portfolio as part of the course, which is a really unique thing in our program. It's a pretty intensive 2-week course. It's comprehensive, but it's not all-encompassing. We cover a lot of topics up here. Obviously, we don't cover things that could be covered, like eye ultrasound and a thyroid ultrasound and a few other things. But I think we try to cover things that we thought were immediately and importantly relevant and enough to cover in a short period of time. We have a feedback system based on scanning and portfolio creation and their application that's really formative. And even our assessments are built to feed further growth in the learner's education, whether it's the image portfolio or their presentations on a POCUS topic. And as I mentioned before, this is one of the areas I'm really proud of. And an example of that scholarship that they create and that teaching that the residents do is this YouTube channel. So there's a YouTube channel where it's all resident-based POCUS teaching, and some of it is fairly advanced, cutting-edge topics like the VEXUS protocol for intravascular volume assessment. So assessing a patient's volume status is like one of the holy grails of medicine, and there's actually a cutting-edge protocol that's being developed in an advanced nephrology and critical care field. And Dr. Stowers, one of our residents, went through the course, brought it down to a very simple level to explain in 20 minutes. I highly encourage you to watch a lot of the resident created content. It's really exceptional. I'm really proud of it. The POCUS course itself has had accomplishments that I think we measure in a few metrics that I try to list here. We have our pre-course to post-course test scores showing improvement in learning and pretty significantly. We've had more and more residents go through the course. And I just want to highlight the number of scans submitted. I counted this actually last night. It was 497 in this academic year that we're just having right now. This is not all the scans they did. This is the scans they had submitted into an imaging portfolio that got feedback and reviewed, and they submitted a read-on. This is not all the patients they've scanned. So that's quite an enormous number for an internal medicine program. I'm really proud of the multi-site adoption. I take no credit for this. There's really fantastic attendings at James A. Haley VA, Dr. Petter, Dr. LaMarche, and the OG, Dr. Piguero, who really started point-of-care ultrasound at USF, several others that I forgot to mention. And Moffitt, I really want to shout out Dr. Yasukawa, who's really helped pioneer use of POCUS at Moffitt Cancer Center. Dr. Oller mentioned a few POCUS workshops that have happened involving live scanning and accompanying didactics. Here we have Dr. LaMarche and Dr. Piguero teaching, looks like ultrasound over here. Dr. Lizama actually helped us organize the ACP Florida POCUS workshop this year, and I'm proud to say that out of the 5 stations that were running for teaching people point-of-care ultrasound, all 5 were run by either USF faculty or residents that went through the POCUS course. So that was all USF. This is Dr. Casals running a POCUS session led by him, one of the resident teachers. He was a chief resident at this point when this picture was taken. And this is a picture from recently, one of the procedural simulations that I did, where we do in the beginning of the year and end of the year that helps with interns, incoming interns and outgoing interns learning, who are becoming second years, learning how to do common internal medicine procedures, often with ultrasound guidance. Here's an example of one with a central line. And I wanted to talk a little bit about the future and some of the challenges and opportunities we have here. I think one of the biggest areas where we have an opportunity to grow is in faculty development, and this is an issue nationally and locally here at USF in Florida. The amount of time and monetary expenses it takes in learning this is significant. So it involves a enormous amount of investment on the part of the faculty and a program. But I'm proud to say that even this year, TGH is going to be doing a faculty development, attending development session for free, by the way. And there are some TGH faculty that are going to get additional training, and I'm aware of Moffitt faculty getting additional training in point of care ultrasound, so that that program can be expanded. And I'm, also proud to say that the course is expanding from just a TGH course to also include Moffitt now, so we can capture more residents. We're opening up a lot of the asynchronous content that Dr. Valenzuela and I created to all, so we capture more residents and we can expand our footprint to more than just the residents that go through the course. And we're trying to grow our longitudinal footprint on residents to capture more of them as well. And finally, I think it takes a cultural growth mindset to adapt and a lot of administrative support to support that culture change. So this technology and the innovation it brings can be honed in for the future. Just want to summarize some of the things I talked about pretty quickly there. I think it's a very important complement to a traditional physical exam. There's a lot of evidence about its clinical applications, and there's further developments to come. It's a new field, growing field. Resident skills are being built at USF with a wide variety of broad-ranging longitudinal and focused training. And I think there's a lot of opportunity in the future for faculty engagement and integration, and look forward to working with all of you on it. Thank you for your time.
Thank you, Nikesh. Thank you, Kellee. I want to highlight one of the things that Nikesh mentioned at the American College of Physicians meeting. That ultrasound session was so successful, being run by USF physicians, that it's going to become a part of the state meeting every year and is being looked at nationally to expand to a similar structure to what we introduced at the last American College of Physicians meeting. That's why it's so good that I'm a part of a lot of the national ACP planning, but it just shows the excellence we have here. This is not the first time that we, as USF General Internal Medicine Residency, have tipped the scales on the American College of Physicians. We did so with a Young Physician Council, which was born a lot out of things we did here in USF General Internal Medicine, as well as patient safety quality improvement, with us having one of the signature earliest programs in patient safety quality improvement in the nation. And that continues to shine under Elizabeth Melzer and Alexis Rice's guidance, as well as all of the faculty who contribute to patient safety quality improvement. So thank you, Nikesh and Kellee, for this talk. I want to turn it over to our chair, Dr. Mosley, who has a question for you guys and some comments. Mark, thank you for joining us.
Thanks, Dr. Lizama. I just want to say great presentations, really enjoyed those. Dr. Oller, congratulations on your well-deserved recent national award. And just really love the focus on POCUS, if that makes sense. It's something I've used for 20 years, and certainly on a night shift, it is your friend when you can't get other imaging timely and you need to make a critical diagnosis. So thank you for that. That's a wonderful overview and very sophisticated what you're presenting here. So thank you. So for Dr. Oller, I had a quick question. As a university-based training program, one of the metrics for our success from the dean's perspective that chairs and departments and deans care about is really the percentage of our graduates that go on to eventually practicing in an academic-based setting. And I know sometimes that data is difficult to get, and you were presenting information from the categorical residency, and that would only be relevant if somebody became a hospitalist or became a general internist. But do we have any sense longitudinally of the percentage of our graduates that eventually enter academic practice?
I don't have a specific number, but I would say my just gestalt would be that definitely over half of the graduates, whether they're staying in general internal medicine like hospitals or primary care, or within their future subspecialty career, or within academic university-based settings for their careers, certainly.
Great. Thank you very much.
Yeah, Mark, that's an excellent question. One that I could probably derive an exact number for you in about a week's time. So I think that's a great question because I have a good knowledge of the longitudinal following through fellowship and also running at American College of Physicians meetings where I went into academic medicine and we filled in the gaps. Jen Newcomb is helping me with the alumni network, which has also filled in a lot of gaps. So I think that's an outstanding question, and I'll get a specific data for you. I agree with right at that mark, and the number of programs that reach out to me asking, give me the people you aren't able to hire. I love the way they ask the question. We know that you're going to try not to let these folks get away. For the ones that you just don't have that space, is there anyone who would consider academic medicine in spot, Y spot, Z spot? So really a testament to this incredible program. And we really have been blessed by leaders such as Phil Altus, Mike Flannery, Cook Mai, and Kellee Oller. And right there, I've described to you a half century of program directorship, which is incredible. And by stating 4 names, that's usually 8 years to 10 years in most places, if they're lucky. For program leadership, I just gave you a half century by just stating 4 names. We'll open it up to other questions. Jen, who else is out there with questions?
Dr. Menezes.
Liz,
Hi, I wanted to thank Dr. Oller and Dr. Kapadia for those excellent talks because I think it gives us such a great overview of what's going on in internal medicine with our residents. I had a question, and I think it ties to both of you because in your roles as program directors and associate program director, and also the POCUS. This is something that we had wanted to start years ago with as part of like a global health elective, either for the students and residents. And I'm just wondering, because you have this 2-week course now, and I understand all the challenges of sending a resident abroad because of the way we are structured in terms of resident salaries and stuff, but I still think we can be creative and figure out a solution. And if you have like a 2-week POCUS course, could you attach like a 2-week elective maybe, or a separate elective, and we can find a donor to get us a mobile ultrasound. That won't be a big issue. And we have partner sites that I'm sure that would be interested in forwarding some kind of a partnership where we could have our residents go as well as our medical students and partner with some of our colleagues in other parts of the world. Is this something that you think we could probably talk offline and see if we can have something for our residents? Because we have such a big residency program, and it is a deficiency that we don't have a global health formal elective, and it's something that we wanted to start for many years, but we've just faced so many challenges. So just wanted to throw it out there.
From the residency side, I know that we definitely have a lot of residents interested in global health initiatives, and I think point of care ultrasound would have a nice foray in medical care in underserved areas, certainly. And I definitely would love to speak offline about some of the barriers with that, related to resident funding sources and sites and all of that.
I would just echo what Dr. Oller said. I 100% agree. It would be an exciting opportunity. Happy to be involved.
Okay, thank you so much. I will reach out.
Dr. Canella.
So that was awesome. I can tell you from a mentoring perspective, I know that Drs. Mosley and Lazama just kind of brought this up, but it's important to know that it really starts with mentoring. And as a faculty member who was an alumnus of the med school and then after residency, fellowship, and everything else came back, I can tell you I think that's critical. I just came back from ID Week, which is a joint conference for PEDS ID, adult ID, epidemiology, and the microbiology societies. And I saw 4 different residents who are from this program, who are all over the continent, not just the country, but the continent, and doing good stuff. And they wanted to touch base with me about mentoring. So it shows that even though those people have gone to some of the most superior places in the country, and I'm not going to tell you who they are or where they are, but you can guess. I can tell you that they still came back to talk with me and others about mentoring. So again, it really starts back with finding good mentors, regardless of subspecialty. And, you know, I've helped other people, even if it's rheumatology or other subspecialties, kind of guide them through. So if the residents really are interested in doing something, finding good mentors as a plural is critical. And I think that's something that the faculty need to be cognizant of when we're talking to residents and fellows and say, look, you know, it's not just day-to-day work, but it's also trying to help you with your career and your life. And I think that's just something that needs to be said. And we do a hell of a job of it here. But, you know, again, it shows that that's something we could even strive to even do even better. That's just my tuppence.
No, thank you, Dr. Cannella, for that. Yeah, we always